the final exam, I just want to make sure that there weren't any questions that were lingering on that. I know that it's been a week, but most of you did good, especially after part 2, you figured things out. So were there any pressing questions that still were unanswered off of that exam that you would like to address or have me address at all?
Did
we know the
posted,
answers?
or
The answers are in my hand.
okay? The TIA question.
The TIA. Was there only one?
Yeah.
I think
It was the percentage of people
Oh, 0 versus-
affected by TIA.
Let me go to that one.
It's like 12? Is that what it
Let me
was?
go.
Or 30?
33.
Let me
33?
find it.
Wasn't 12 another one? 10 or 12?
I didn't see
Was
that.
that the
I think it's with
the vitals? Long sounds? Long
Oh,
sounds
man.
one?
Oh, no, that was,
Was that 10 or
I think
12?
it was 10.
That's, yeah, I was gonna ask that one too.
What question is this the one you're asking? What is the mortality rate
Yes.
for the patient population suffering from a transient ischemic attack? The choices were 0%, 5%, 15%, or 33%. And the answer is,
33%?
33.
somebody please give me the definition of a TIA.
So it's
That does not give me the
It's-
definition. Somebody give me the definition in a succinct sentence of a TIA.
a stroke, stroke-like symptoms that resolve within 24 hours.
How do they resolve if they're dead? A TIA are stroke-like symptoms that resolve within 24 hours and usually within 10 minutes. So what's the mortality of a TIA?
0.
You
But it
can't
says
die of
the-
a TIA because then it's not a TIA.
So I misunderstood the phrasing, I guess, and
What
it's
is the
like,
mortality rate for the patient populations suffering from a transient ischemic attack?
right, and so like I took it as like that patient or those people have been like suffering with this problem, like this is a history
History
of it.
of
And so
TIA.
Right.
when I did research on it, like 33% came up, and so I was like, well, maybe
33% of TIA patients do what?
Have a mortality rate.
mortality rate.
Have a major stroke within the next 30 days. Of which, does everybody die of a major stroke?
No.
I got it right on,
Thanks, Nene.
I got it on the test.
So a TIA
that's what I
has a
thought.
0% mortality. Has a 0 mortality.
Like I knew that.
Because you cannot die of a TIA.
Because it
Because
resolves.
it resolves. That's the whole definition. If it doesn't resolve, it was not just a TIA.
Right.
It would have been
A stroke.
a full blood.
Or they died from something else.
Oh, yeah.
Can we talk about 10?
Sure. Sorry. Didn't we? Wasn't there a group that we went running around
Yes.
this for a while? Okay.
I still don't know the answer.
I still don't know the answer.
Great. I think Challen was the one that was making the biggest argument, wasn't it?
Probably.
That was incorrect.
I don't know, that I didn't know, so it wasn't my gut.
During your assessment of a thoracic trauma patient, you failed to adequately assess lung sounds. Which of the following differential field diagnosis would be most negatively impacted by this action? Somebody tell me what the question is asking. What's it asking?
If you don't have a clear picture of your lung sounds and then go to reassess your lung sounds, how do you know that there's a change from the beginning, from the first set to the second set, to trend where the difference in lung sounds is?
Okay, let's break down the question first of all. If I were to do a concept map of this question,
You did something wrong.
if I were to do a concept map of this question, what would the heading of the concept map be?
Lung sound.
You did something wrong. You checked the lung sounds wrong.
Assessment.
Assessment wrong.
What can you be more specific?
Thoracic assessment?
Adequate assessment, or
Thoracic assessment?
Can you use words that are from the question itself?
Could you read the question
lung sound
again?
assessments.
Okay, that's what I thought you were going. So the big heading here the big heading here is differential diagnosis. That's what this question is about, okay? It's about being able to distinguish between differential diagnoses, right? Underneath that concept, it's differential diagnoses of
Lung sounds.
Thoracic.
thoracic trauma.
Trauma, yeah.
That's the next part of our concept map. So it's a differential diagnosis question of things that go wrong in the chest cavity. Yes? And then the next level is
Lung sounds.
diagnoses affected by lung sounds. Meaning, which of the following here would you need lung sounds to distinguish between the two? So let's start with tension pneumothorax and pneumothorax. Are lung sounds going to help you to distinguish between a tension pneumothorax or a hemothorax? Let me ask you a different question. What will the lung sounds be with someone with a tension pneumothorax?
Absent or diminished.
On,
The
Affected
affected
side.
side.
okay, and with someone with the hemothorax?
Same.
Absent or diminished on that effect.
Okay, so not knowing the lung sounds wouldn't have helped you to distinguish between those two, right? What about a myocardial contusion and aortic aneurysm?
Lung sounds don't affect
Don't
that.
affect it. Yeah.
Because lung sounds will be
Same or
the
more.
same
Yeah.
between those two. Knowing what the lung sounds are can't help you to determine if the heart is bruised or if there's an aneurysm, because those aren't affecting the lung sounds. Does that make sense?
And your-
Or if there's an effect of the lung sounds, it's global on both sides, so it's not differential.
And the treatment plan wouldn't be affected. Either
We're
way.
not talking about treatment plans. Don't add stuff to the question.
Okay.
We're talking about differential diagnosis based on lung sounds, right? Myocardial contusion and a pulmonary contusion. So the tissue
Lung
is
sounds
bruised.
aren't going to be affected.
Lung sounds won't be different, right? Give me the, so you already know what the answer is.
Yeah.
Because we just figured out that it doesn't help with any of the other ones. So please tell me what the signs and symptoms are of a pericardial tamponade. Give me the key signs and symptoms.
JVD,
JVD,
Narrowing pulse pressure.
narrow,
narrow pulse pressure.
muffled lungs, heart sounds.
Muffled heart sounds. Anything else? What's gonna happen to cardiac output?
It's going to go down.
We're gonna drop cardiac output. What's gonna happen to blood pressure?
It's going to drop.
I'm gonna smack you so hard one of these days when you answer my questions
I
like that.
deserve
How
it.
many times have I come back with this?
Yeah.
Tell me what's gonna happen to blood pressure.
The systolic is going to drop.
You're gonna drop systolic, right?
Mhm.
Yes? Tell me what the
Signs,
signs and symptoms of tension pneumothorax are.
JVD,
JVD,
tracheal deviation, subcutaneous emphysema.
tracheal deviation, we'll come back to that, but maybe sub-Q emphysema. What else?
Absent lung sounds, absent or diminished.
Absent, lung sounds, great, what else? What else?
Hyperinflation
Hyperinflation?
on the affected side.
On the affected side, okay, that'll
Same with
cover
absent.
that. What else? Why do you have JVD?
Because it's pushing on the heart, which is
So what else are you gonna have?
So then you'll have muffled
Decrease
lung,
cardiac
heart,
output.
Decrease cardiac output,
and decreased systolic blood pressure.
decrease systolic blood pressure, and
Narrowing pulse pressure.
narrowing pulse pressures. Yes?
So they're all the same.
Look, guys. What is the only thing that shows the difference here?
Lung sounds.
What's going on with the lungs? That
Inadequate.
is the key thing that helps you determine the difference between a tension pneumothorax and a pericardial tamponade. What kills you in a tension pneumothorax?
The pressure put on the heart.
The heart things. What kills you in the pericardial tamponade?
The heart pressure.
But you
So the
can't,
same thing is gonna kill you in both of those events. But the only way you're gonna be able to tell the difference is if you have something that you see in the lungs. and which one can you treat the fastest and the easiest?
The ones in the lungs,
So now we can add treatment in there, which one would be detrimental for you to not have distinguished between,
tension
based on
pneumothorax.
your lung sounds? Make sense? Are we all clear on intent now?
Yes.
Fantastic.
27.
Which one?
27.
27. Dispatch sends you to a nursing home at some time with a old lady who woke suddenly from sleep and able to speak clearly. She went with a headache. She has refused to take her AFib medication last week.
Yeah.
The staff states that she is very alert and oriented, usually, and which in the following do you suspect? Okay, well, first of all, what does she have?
Stroke.
Is there any question that she's having a stroke?
And it's a
And what is the underlying condition that she had to
AFib.
begin with that is probably gonna lead to the stroke?
AFib.
Good, so AFib is what it is, right? And AFib is going to lead to a stroke because why?
embolism.
Where is
A
the
clot.
blood pooling that's causing the problem?
In the
Right
heart.
atria.
Where?
Right atria.
So I've heard all kinds of stuff, of which, none of which are exactly right, and it's not specific enough. Where are we concerned about AFib blood pooling?
Left atrium.
The left atrium. The left atrium is our concern. Because that is the only place it will pool. It's not the only place it pools, but it's an atrial fibrillation, which means the atria are not contracting, yes? So blood is pooling in both the right and left atrias, right? But the one we're concerned about is the left atria, because why?
Because then it goes right to
The body.
carotid.
Right?
And that's the
The
stroke.
right atrium goes to the
Just
lungs.
the right
You
would
get-
be a pulmonary embolism.
So you have your heart and your aorta, right? We're concerned about the blood pooling here because it's gonna go to the left ventricle and then up into the aorta, right? And the way that the blood is ejected into the aorta, right? It's movement of blood. And Newton has a law that kind of talks about the movement of stuff,
An object in motion tends to stay in motion.
unless,
It stops.
Good, so the blood isn't just gonna follow the aorta, the blood is gonna
Shoot to the back of it.
keep going like that, right? Which means the carotid arteries are actually in a perfect position to receive that blood flow there, and when it hits that, some of it will be out of back heading that direction. The carotid arteries are in the perfect place to get that first flow of blood that comes into the aorta, on purpose. The body's pretty cool that way. It's made pretty efficiently, right? But our concern is that at left atria, stagnated blood had clots in it, right? We're not worried about stroke from the right atrial clots, because why?
They're gonna go to the lungs.
They're gonna get filtered through the lungs. But there's no filter between here and the brain on the left side. So therefore, those clots are a problem. Now, a clot that starts here but causes damage up here, that clot is a what?
Embolic thrombolysis.
It's an embolus. An embolus is any object that is moving from one place to the other in your blood. So it's an embolic stroke. What is the difference between an embolic stroke and a thrombotic stroke?
Thrombus grows in that
Start.
place.
Huh?
A thrombus grows in that place.
A thrombus is developed in that place.
I guess the other question is, they're both considered ischemic.
They're both ischemic strokes.
So-
So if we're looking at this, cerebral stroke just means a stroke where?
Right.
In the brain. Ischemic stroke is what kind of a stroke?
Lack of oxygen.
Let's say that again.
Lack of blood flow delivering oxygen.
Good, usually because of a clot, but it would be because of other things, but because of a clot. A thrombotic stroke is one that grows in place, and embolic stroke is one that is moved from one place to another. So you could have put a cerebral stroke here or an ischemic stroke, but it would have been wrong because why?
Because it's not.
We have more
specific
information. We can
Yeah,
be more
because
specific.
both of them would include a thrombotic stroke, which she is not having, most likely, right? Because it moved. And the AFib is what gives you that clue. And that is our concern for people with AFib, which is why they are what?
On blood thinners.
On blood thinners, right? Good. Everybody clear on that one?
Yep.
Any others? were those the only two?
I'm just looking as you flip.
Oh, could you clarify 34? The only thing we couldn't, I don't know if the group ended up finding it, but like whether the temperature
Oh, yeah.
increases or decreases in that one.
Wow. Wow, Brooke.
Tested or something?
Annalise, all you have to do to get the spotlight off you is just ask Amanda about something.
So,
They both got
how's Newport?
Okay,
I don't know. Oh my god. Let this day end.
It's just
There's always tomorrow.
okay. Which of the following accurately reflects Cushing's reflex? So we're talking about pulse, respirations, blood pressure, and temperature are the ones that we're dealing with, right? So we know that in Cushing's reflex that you're going to have a overall change in pulse, in which case it's going to go what direction?
Increasing systolic.
I have no idea what that has to do with pulse.
Decrease in pulse.
Decrease.
But sure,
Yeah,
you're so hell-bent on the blood pressure thing.
I know. It's like, don't say blood pressure. Okay, systolic. Okay,
So our pulse is going what direction?
down.
Down because of the involvement of what system? The parasympathetic. Good. Our respirations are a little. That one's a little bit funky to put it into an overgeneralization like that. But the key is that during our Cheyne-Stokes breathing, we have periods of what?
Decrease.
Of apnea,
Yeah.
which is really what they're trying to get at. That it does increase into kind of a hyperventilation that then decreases into apnea. And it's that decrease into apnea that we're referring to right now. What has happened to blood pressure and the specific one?
Systolic is rising.
Good. That's good.
Both
and
are.
both are actually going up a little bit.
But the stalk faster.
But now you have this massive increase in blood pressure and blood flow moving around. Plus you have this decrease in pulse, which is redistributing blood flow like crazy. And so you actually will also see an increase in temperature. You also have a change in the hypothalamus that will also cause the body to try to increase temperature as well. And so you get an increase in the temperature, in their temperature, as you're also increasing everything else.
And vasodilation would have that too, right?
Well, the vasodilation, vasoconstriction is a little bit funky because you do get some vasoconstriction from the sympathetic involvement,
Oh, okay.
right? But it's definitely being countered also with, and that's why you see that diastolic go up,
Yeah, oh, I see.
right? So it's kind of independent of that this time.
I was thinking the dilation would cause increased temperature.
Any others? Everybody good for the rest of them?
62 and 63.
Thanks for asking all the questions that we don't want to ask.
You're welcome, I did. It was bothering me. Like
I just don't
wanna
have the
know,
test in my hand in front of me. Oh.
62. Okay.
Yeah, that was a fun rhythm.
So we're trying to find out what the patient is experiencing, yes?
Mm-hmm.
Okay, so it looks like we're trying to distinguish between right and left funnel branches, right? Funnel branch blocks. So give me the criteria for
Wide QRS, supraventricular,
supraventricular rhythm. Thank you. Wide QRS.
Slurred S wave.
And now we split between right and left. What's right?
Slurred S
Slurred S in lead 1 and V6.
the R prime or QR and Q1 or V2.
RSR or QR in V1, possibly V2. Left?
Monomorphic in 1 and V6.
Monomorphic,
QRS.
monomorphic where?
1 and V6.
In lead 1 and V6, can you be more specific? Monomorphic
QRS.
positive
Oh, yeah.
and
Discordant.
monomorphic negative where?
In V1,
In V1 and
V2,
throw V2 in there as well,
and
right?
discordant
And
TAs.
discordant T waves in those, right? Okay, so let's start with
I
this.
have a question about
answer.
the monomorphic. Can you please explain what the heck that is?
Yes, means your QRS complex is all positive or all negative, or so close to being all of that that in V1 it's a little bit weird. I had a caveat to that in V1, but all positive or all negative. Monomorphic meaning singular morph, not that's a monomorphic QRS complex. That's a biphasic QRS complex.
But when we refer to P waves and monomorphology, we're talking about the series of P waves having a similar shape.
Yes,
So why is that different?
it's not different because we're just having to talk about QRS complexes. All the QRS complexes are, yeah, okay, I understand what you're saying. So,
Because that makes me think that that is fundamentally different than polymorphic.
yeah, so we are using the definition of that in two different ways, so.
Monophasic?
What are you doing to change that?
That's a really good point. You understand what her question is?
No, more like
Okay, so here's
monophasic and
her
biphasic.
question, and I'm glad you asked that, because I'm sorry that wasn't clarified before. When we look at PVCs,
Mhm.
and we have a PVC that looks like this, yes? This is what the PVC is looking like.
Every time.
So it's a QS, or I mean an RS, right? And in a PVC, we say, are all the PVCs monomorphic? We actually are referring to the entire QS complex as one unit. And we're looking at this entire QS complex compared to this entire QS complex. And we are saying they are monomorphic because they are the same, the entire QS complex. In this context, we are actually talking about within the QS complex. Monomorphic meaning within the QS complex itself, it only has one wave that's going one direction. So we're using that word in two slightly different ways, where this monomorphic is talking about within the QS complex, and the monomorphic we use here, we're talking about the entire QS complex as one unit. That should have been clarified before. I'm sorry that was a little unclear. Does that make sense? So when we were using monomorphic in the context of bundle branch block, we were meaning that within the QS complex, it only goes one direction. Either all positive, meaning an R wave, or all negative, meaning an S wave.
And then when you're talking about your discordant T waves, is that discordant to every QRS complex? Or is that specific to your lateral leads and your
Discordant,
septal?
yeah, good question. Discordant only to the QRS complex in the lead that we are referring to. So in this
Okay,
case,
that's
this would be,
but you're gonna have that on a STEMI.
yeah, you might. No, not
So
necessarily.
why is
You may
that
or may not.
why is that a distinguishing factor?
It's not a distinguishing characteristic, it is a, well, it is. Okay, so first of all, you may or may not have it on STEMI. You're talking about a flipped T wave.
Yeah,
That's true. However, if we were to have this, well, that's my QRS complex and that's my T wave,
yeah.
it would not be a criteria for the bundle branch block. So you're right in saying that that flipped T wave might come in a STEMI,
Yeah.
but we have other criteria that deal with that STEMI also. But if you have a if you have a monomorphic QRS complex and a concordant T wave in V1, it would not be a bone brush block. Something's not right about it. So it's one of many criteria for you to do to make sure that that it is what.
Because you need it to be repolarizing incorrectly.
Not because you need it to, but because it will in a bone brush block. Remember that the EKG is a picture of what's happening. So that's what it will do under that circumstance. So it's not a defining characteristic, it is one of many things that we will see in that bone brush block. Okay? So, let's take a look at this for just a minute. Do we have slurred S waves in leads 1 and V6?
No.
Mm-mm. And are we calling it a supraventricular rhythm? Yes. That's right.
My question is, do we have slurred S waves in leads 1 and V6? Let's look at V6 first.
Yes.
Is there a slurred S wave in V6?
Yes.
Sure looks like it. Do you disagree that that is a slurred S wave right there?
I do not disagree.
Got it.
That looks like a shit show.
Show radio.
Yeah,
I
Annalise.
love that. You really need to start with this quote.
What do you have there, Dustin?
Huh?
What do you have in the bag?
A blueberry muffin. So I'm trying to hide it for as long as possible. Not from you, but from my own self. Will.
Damn it, I forgot to weigh in for the pet.
Was it over?
Did you weigh in?
I don't need to.
I mean, everything's been not good. Not good.
They also have like 3 degrees of the crossover of them, and it's like 6 feet to like 1 or 2.
Okay. So we have V6 right here, right? Good? So here's my QRS complex. Right? Does that look like a slurred S wave? QRS complex is wide. Where does it widen?
All of them.
At the back end of
At the
it.
back end, which is consistent with the bundle wrench block, right? And that widening is happening in the back end of the QRS complex that is on the S wave. Do we agree with V6? Okay? So,
Can you
yep.
draw in red the part of the QRS that is the slurring S wave? And then that peak that comes up to be your T wave.
This is my T wave.
Yeah.
That's correct. My J point is probably right there. There's my ST segment, my T wave. Right? And it's happening every time in V6. Do we agree? Do we agree there's an S wave in V6? So an S wave? Okay, so then we have to look, let's go back up and look at V1.
No S wave.
Okay, what do you think about lead 1?
Looks pretty monomorphic.
Yeah, it looks pretty monomorphic, right? We know that the T wave is right there, right?
Yeah.
That's where the T wave is?
No.
Yes,
Why do we know that that's where the T wave
because
is?
we can see it on
Big
the leads
T wave
too.
right there.
Because it's right there. Because we look in the leads.
Man, I've been pissed off at that T-Way for so long.
What is, does this have an S wave?
Not really.
No.
It's got to,
Okay.
right? Because we're just looking at what's coming below it. It's a fairly biphasic S wave. I mean, it's a fairly non-existent S wave, but is there an S wave there? Good, okay. But does it look kind of strange? It actually doesn't quite look like a slowed S wave. Where does it look like things are widening out in this?
It's beginning.
Yeah, it looks like in the arms where the widening out is,
Yeah.
right? Okay, so that's confusing. So V6 shows us kind of that traditional right bundle branch block look. What does lead 1 kind of show us? Kind of shows us a left bundle branch block because look, it's, I've got the criteria. The left is, what's the the criteria for a left bundle branch block in lead 1? Monomorphic, right? Monomorphic with a discordant T wave. Okay? Well, it does look like that's discordant. It looks kind of biphasic actually. I almost can't even tell. But something's weird about lead 1. It doesn't seem to quite follow that criteria for a right bundle branch block, even though V6 does. Okay, well, we can put that in our hat for just a minute. We'll smoke it later. What do we do?
That's
Where
nice.
are we looking next? What lead do we look in next?
V1.
V1. So in V1, we should have kind of an RSR pattern, right?
Or negative.
We should have an RSR pattern or a QR pattern.
As if anything else.
Does it look like we have that? So that really doesn't meet the criteria of a right bundle branch block.
But there's
Okay, well, let's talk about left bundle branch block. What should it be as in a left bundle branch block?
monomorphic and
Monomorphic in
discordant.
what direction for V1?
Opposite V1.
What should it be in V1?
Negative.
Negative in V1. Is it negative?
No.
So that doesn't quite meet the criteria of either of those either, does it? Oh, so do we have a right bundle branch block?
No.
Do we have a left bundle branch block? So that means we have neither of those. Okay, so we at least know that one of the answers is there, right? Because it doesn't meet the criteria of either of those bundle branch blocks. So the next question was whether or not it was what, a third degree? Is that what I asked? With an idioventricular focus. So